All right, so here we're going to talk about virus infections of the lower respiratory tract. And so for virus infections, we have, of course, influenza. Influenza is in the family orthomyxovirus. It's a single-stranded RNA virus. It has many strands of its RNA. It has a very high mutation rate, which is the reason for the annual influenza vaccine. There are three main serotypes of influenza. There's A, B, and C, and these are going to be differences based on the hemagglutinin and neuraminidase proteins on the cell surface. So one of the big complications associated with influenza is recombination of human viruses with avian viruses, and this will typically make a very highly pathogenic new strain of influenza. Humans are the host. Aquatic birds are the reservoir for this. Now, influenza has seasonal versus pandemic, so what's the difference? Well, seasonal flu is going to be contagious. It's an illness that's caused by influenza A and influenza type B. These are going to have short epidemics, so we can have animal influenza cause epidemics among people. And pandemic flu is a global outbreak of typically a new flu type A virus. It's usually not the B virus. And it's very different because it doesn't have any association or link to circulating seasonal flus. So it's a jump. So we typically refer to our seasonal as drifts. So not very big changes, and our pandemics as shifts. So a big jump in the makeup of the actual flu virus that's circulating. So epidemics of our seasonal flu are going to happen from year to year, and it's typically going to be seasonal. We know flu to be circulating in the fall and in the winter. And then flu pandemics are going to be very rare. So here's a timeline of some of the more recent flu pandemics over the past 100 years. And so the last one we've had was in 2009, or H1n1 pandemic. So seasonal flu virus is going to spread mainly from person to person, and this is going to be droplets, similar to what we're seeing with SARS-CoV-2. So if someone's coughing or sneezing, within 6 feet of a person. Our pandemics are going to spread the same way as seasonal, but a pandemic virus will more likely be able to spread to more people because we don't have any immunity to the pandemic strain. Now, the vaccine for flu, there is a seasonal vaccine made each year, and everyone 6 months and older should get this vaccine. For most people, you only need one dose, and they have higher antigen load in vaccines for elderly people over the age of 65. Now, pandemic flus kind of sneak up on us, so the government is going to have a stockpile of pre-pandemic flu vaccines and 2 doses, and they want to, or hopefully if a pandemic strain emerges, they're able to generate a pandemic flu vaccine pretty quickly. Medications, there are drugs that will treat seasonal flu. They're antiviral drugs. However, these drugs have to be given very early after infection, and they are limited in the amount available. So if there's a severe epidemic, it could become a problem. For a pandemic, again, you're going to have the same drug arsenal available. However, it's not known if the pandemic virus will be resistant to that drug until it's tested. In addition, because the pandemic flu can infect more people, there's a chance that there's not going to be enough of these drugs to go around. And the drugs do not eliminate flu. They target a protease that's involved in assembly of the virus particles. So they're not going to prevent infection by flu. They're going to prevent the virus from being able to assemble into more virus particles inside your body. Who's at risk? So children, young, and people over the age of 65 are at higher risk. There is some risk associated with pregnant women, but typically in a seasonal flu environment, it's usually those over the age of 65 with respiratory comorbidities that are at highest risk. Who is at risk for complications in a pandemic flu? Well, this can depend. Healthy people and adults typically had higher burdens with respect to pandemic flu, and primarily probably because they're out more and being exposed more to the actual flu virus. So, influenza. Influenza is going to stay in your respiratory tract. It rarely gets out in your blood, so it likes to stay in that area, confined in that area. It's going to replicate in the ciliated cells of the lower respiratory tract, kind of a normal target for respiratory virus infections. You're going to have these ciliated cells shed, and so the local inflammation is caused by virus destruction of the tissues of the actual lower respiratory tract, your lungs. Importantly, you have convalescence stage here. And this is typically what we're seeing also with our SARS-CoV-2. So respiratory epithelial cells do not repair themselves overnight. And after an influenza infection, it could take up to 10 weeks to restore those respiratory epithelial cells. And again, this is seen in other viral infections as well. Measles infection will have the same effect. SARS-CoV-2 will have the same effect. And it's not specific to the virus, it's specific to the locations. It's your lungs, and they take a while to restore. And you can also, with respect to lung infections with viruses, have bacteria and superinfections. And again, this is not specific just for flu. This is specific for the location being the lungs. So a superinfection following a respiratory syncytial virus is common, following measles virus is common, following influenza virus is common, and also SARS-CoV-2 is common. Now, the host response to influenza is going to be similar to any virus infection. You're going to get an interferon response, and this is going to be a host mechanism to slow down the virus. So interferon is our speed bump. And then we'll have our natural killer cells, our CD8 cytotoxic T cells, and antibodies that will come in and clear the infection. Remember, our CD8 cytotoxic T cells are the most important for an intracellular infection, and flu is an intracellular infection. Now, the actual symptoms are going to last 3 to 5 days, so it's going to be very short. And again, your immune system kicks in gear and clears it pretty quickly, but your convalescence stage can be prolonged. You can have a progressive infection that will further damage your bronchial tree, your lungs, and you can get a lethal pneumonia that can develop. 3 most common superinfections, surprise, surprise, are normal flora guys, strep, and staph. Haemophilus influenza used to be a common superinfection, but we have a vaccine, so as long as you're vaccinated, that bacterium should no longer cause you much difficulty. But our streps and staph will move in rather quickly once influenza has created a space for them, got rid of those ciliated cells, and they like to get in there and cause pneumonia. So you can have death in 3 ways. You have an underlying disease. So people who are over the age of 65 with some sort of comorbidity have a high incidence of death associated with flu. You can have a superinfection with bacterial pneumonia. However, this is not as prevalent as a person who has an underlying respiratory illness. You can also have just too much virus present, too much bacteria present, that leads to an overwhelming viral pneumonia or an asphyxia because of the location. Treatment for flu, you have care for symptoms, so trying to control the flu-like symptoms, fever, and you can also have anticipation of complications, so treatment of the patient with antibiotics or anti-inflammatories. Rest, fluid intake, things like that also are very important. Let's see, you can also get Tamiflu if you are diagnosed and it's delivered within 12 to 24 hours of your exposure to flu virus. However, that's a very short window, of course, and so it's not effective after that. And it's because it's about numbers. So Tamiflu toxicity, you can't take a large amount of it, and if you have a lot of virus already present, it's not going to have much of an effect on that large presence of virus. However, if you get it very early, where you have a small presence of virus, Tamiflu can have an effect. And of course, annual vaccination is highly recommended to stay on top of the circulating strands so that in case we do get a jump, you may have some immunity to that jump. Now, another virus is respiratory syncytial virus. Respiratory syncytial virus has its syncytia in its name. So syncytia is a fusion of cells. And so again, this is not unique to respiratory syncytial virus. Many viruses can fuse cells together, and many of them can form syncytia. Now, respiratory syncytial virus is associated with fall to early spring outbreaks in communities. Your virus is going to be shed for about a week. In infants, this shedding can be prolonged. It's going to be a major cause of nosocomial infections, again, debilitated patients. And control is going to be by just hygiene, hand washing, exclusion of staff and visitors with respiratory symptoms. Now, what's interesting is this shows a graph of the transmission of respiratory syncytial virus, and it really is that fall, winter, and early spring months. And your spread is going to be in the community. So if you've had respiratory syncytial virus, you do have an immune response against it, but it doesn't mean you're not going to ever get it again. And so what's common is to have reinfections occur. You don't get the severe symptoms because your immune system kicks in and clears it, but it's such a contagious virus that you can spread it to people who potentially can get more severe infections, such as your own children or the elderly. And one of the key things here is that we typically think of RSV as an important childhood infection, especially in the first year of life, and that is very true. But it also is a very important infection in the elderly, especially those that are debilitated in a hospital setting. So RSV is going to spread to the upper respiratory tract. The infection usually is going to be associated with the respiratory epithelial cells. And it does the similar thing that influenza did. It's going to wipe out those ciliated cells. Again, your cytotoxic T cells are going to be important for clearing this. You could have complications associated just by location. The bronchi and bronchioles can get damaged. You can get plugging of the airways, etc. You typically are going to have a very short incubation period, and you're going to have rhinitis as your first onset. And then you're going to have about 3 days of symptoms. So RSV is important in small children. So small babies, typically with this infection, will refuse to eat. They can be very irritated. They have trouble breathing or have a shortness of breath. They can even have a cough and have yellow, green, or gray mucus. Also, signs of dehydration are no tears when they're crying, fewer wet diapers, and their skin can be cool or dry. And so clinical signs, again, are hypoxia, hypercapnia, pulmonary collapse, and these signs and symptoms can last about 10 to 14 days. In children and adults, this is going to be milder. In patients who are debilitated in a hospital, it can have very similar symptoms that our infants did. Fatality in infant rates in hospitals is about 1%. In immune-compromised children, the fatality can reach about 15%. So children who are undergoing chemotherapy for cancers are an example of those. So there is no vaccine yet available for RSV. A lot of people are working on that, but according to the CDC, it's not available yet. We have some oxygenation and ventilations that can be used, and you want to deal with potential for superinfections by your bacteria, similar to what you would see with a very severe influenza infection.